It's the first manifestation of MEN1. It occurs earliest. It has about a 100% penetrance. It means if you have MEN1 and you've done a hyperpara, it's like impossible. And when it's treated, there's a chance that it isn't going to go away, and there's a chance that it's going to come back. And so when it does come back or it hasn't gone away, you got to deal with that and try to figure out what you want to do. So here's the question. My hyperparathyroidism just came back. Now what do I do? Just to begin with, a really quick overview of the difference between people who do and don't have an inherited form of hyperparathyroidism. So this is just the clinical features of sporadic hyperpara versus the MEN hyperparas. And what you can see from the board is that people with MEN, they get their hyperpara about 2 or 3 decades earlier than people that have non-inherited versions of the disease. So they get it earlier. In your 20s or your 30s when you have hyperpara. Could even be earlier. We saw from Zimmerman this morning, 8-year-olds can get hyperpara. So if we see hyperpara in a young person, we think about MEN1. The female to male ratio for people who did not inherit it, about 75% of people are women and 25% are men. But that ratio gets really close to 1-to-1 in MEN because it's just the genetics. It has nothing to do with the sex. Persistent disease after therapy is pretty rare for people that have sporadic disease, but extremely common for people that have MEN1. If you have MEN1, the chance that your operation will fail you is about 1 in 4, about 1 in 4. So that's pretty high. And then also the chance that you will recur if you're cured is about 2/3. So 2 out of 3 people. If you just live long enough, that's what I tell people when they see me. I say, if we fix you and do a subtotal parathyroidectomy, if you live long enough, it's going to come back. Because that one little piece of parathyroid that we leave behind, it's going to grow at some point. Over enough years, it's going to come back. The real problem here on this slide that you're looking at is the permanent hypopara rate. And that's something that MEN1 patients have a really high chance of facing. 20 to 65% of patients with MEN1 at some point in their life will become permanently hypopara, where their calcium is low and they're dependent upon calcium pills all the time. What else is different? Family history, of course, is absent in sporadic patients, as well as sporadic other tumors. Also, I should put up there bone disease. I think bone disease is a lot worse in MEN patients because the disease starts a lot earlier. So if you start getting hyperpara when you're 20 or 30, then by the time you're 40 or 50, you already have osteopenia or osteoporosis, whereas people who are sporadic don't start until they're like 50, you know. So I think the bone disease is a lot worse. The preferred procedure for people with non-inherited disease is either a focused parathyroidectomy, a minimally invasive, or a 4-gland exploration. Either one's okay. But on the other hand, if you have MEN1, you should be getting a 4-gland exploration, always. And you should have also a bilateral cervical thymectomy because of the high probability of having additional parathyroid glands. That's pretty agreed upon in the United States and Europe. People with MEN2, it's a little bit different. You could make some arguments for a more focused approach in MEN2 because they don't have an overwhelming incidence of 4-gland disease like they do in MEN1. So that's kind of the key differences. So let's say you've had hyperpara, you've had surgery, and now it's back. And so the first step for you is to ask some questions. Do I really have it again? Is it really back? And you've got to really make sure, because just an elevated PTH may not be enough to mean that the disease is back. And also, how severe is it? Are we talking about a calcium of 10.6 or a calcium of 12.2? And that can make a big difference as well. And the final question in this phase, I think, is, do I need to do anything about it? I think most people don't probably initially do anything about it, and they get watched for a while. So to address the first issue, do I really have it or not? This is how the doctors try to figure it out. We're looking for a high calcium at the same time as a high PTH. And there's a whole laundry list of things on this slide that I don't need to go through that help the doctors understand whether you do or don't have hyperparathyroidism and if it's back or not. Here's an interesting one. Elevated alk-phos, really non-specific. Alk-phos is elevated in people with hyperpara if they have high bone turnover. So if they're getting osteoporosis and their bones are kind of thinning out, you'll see high alk-phos. So it's actually not really a diagnostic thing, but it's a secondary thing. These are symptoms of hyperpara, and this is by no means a complete list of symptoms that people have. I've put little asterisks on the page where the symptoms are proportional to how high the calcium is. So the higher your calcium is, the more fatigue you have, the more muscle aches and pains that you have. All of the other symptoms it's kind of hard to predict. People can have a calcium that's relatively high, like 11 or so, and say that they feel totally normal. And then people can have a calcium that's barely high, like 10.6, and have all sorts of symptoms that are pretty bad. So it's hard to know just by an absolute calcium number how many of these symptoms you might have and how severe they might be. The way we think about it, though, is you should have it treated if you have symptomatic hyperpara. So if you have symptoms and you have hyperpara, then we should probably do something about it. And people should say to you, yes, surgery or a treatment for hyperpara is a good thing to do if you have symptoms. Now, if you don't have symptoms, there's a whole list of things that you can do, or sorry, things that you should look at to try to determine if a person should have treatment or not. And I put them in here. This is actually expert guideline things. So there's total serum calcium being 1 above normal. So in most cases, normal is 8.5 to 10.5. So if your calcium's coming up around 11, 11.5, then people are going to start telling you to have something done. This is telling you, the doctors are asking, is the kidney working normal or is it slowing down? So a person with a slower kidney, it's more important that they have it taken care of. If your kidney is working really hard to get rid of that calcium, so the urinary calcium is really high, this is another indication that you probably ought to have something done because you're more likely to get maybe kidney stones. The younger you are, the more important it is to deal with it. If you have osteoporosis somewhere already, it means that you're at higher risk of bone fracture. And so that's a good reason why you ought to have something done. If you already have kidney stones, then you're expected to get more and more kidney stones. So if somebody hasn't gotten kidney stones yet, you just kind of wonder, well, maybe it's not going to be too bad. But once you start getting them, they think you're probably going to keep getting them and they're going to be more. And so if they know you have kidney stones, they're probably not going to watch you so much. Also, if you've got a fracture, so like this goes along with osteoporosis. If you have osteoporosis and you have a fracture, then the thought is you're going to have more fractures. So yet another reason. And then also, I think that it's reasonable to recommend surgery for people if they just can't be watched. You know, they live on the moon. I don't know. They live somewhere where they, are not going to have access to doctors, or they just want to have surgery, and the doctor that they see is saying, don't do anything, but they really want it because they think it's the right thing. I think that's okay too. So next step, is this recurrent or persistent? So you had surgery. Did it actually go away, or did it never go away? Or did it go away for a while, now it's back? Do you think we're dealing with one bad gland or multiple bad glands? And where might those bad glands be, by the way? Because that might make a big difference where it's at. And just for definition purposes, there's persistent hyperpara and there's recurrent hyperpara. And persistent disease means that your hypercalcemia never went away, or maybe it went away for a little while, but then it came back in less than 6 months. That's persistent disease. And it's either due to an inadequate resection, which means that they should have taken out more parathyroid tissue, or maybe you got in line twice, for parathyroids at some point. Instead of 4, you got 5, or you got 6, or you got 7, or something, and so the doctors took out 3.5, but there's a couple more to go. And then there's recurrent disease. Recurrent disease means that your hypercalcemia went away, and it went away for at least 6 months before it came back, and now it's back. And that could be because we whittled down the amount of parathyroid tissue that you have down to 1/2 of a gland. You lived enough years, and that 1/2 of a parathyroid gland grew back. It grew bigger over time, and now it's there, and it's overactive, and it's too much. Or it could be that case I just alluded to where you have a 5th gland or a 5th and a 6th gland in the thymus somewhere that used to be really tiny, and over the course of years has grown back. What we do to try to answer where might this be is we use a lot of imaging. I'm not going to spend 30 minutes to show you all the different imaging studies. This is a really cool study that I did recently on somebody. Couldn't find the parathyroid on ultrasound, like the normal stuff we did with a sestamibi. It's just a fancy sestamibi scan with a CAT scan built in. And we've got this really bright dot that's sitting directly behind the trachea, right behind the airway, right in between the airway and the spine. You can never see this thing on ultrasound because the windpipe, you can't ultrasound through. You can't see behind it. It's like a shadow zone. It's totally black there. And on ultrasound, you can tell where this thing was. On this thing, it's obvious. It's like a giant light bulb. Look at that. It's a giant light bulb on the picture, right? You know what? It's actually pretty easy for me to take out. It didn't take me very long at all. It took me like a half an hour or something to get to that thing. But if I didn't know where it was, and I was just kind of randomly exploring that patient, I've been doing that for 5 or 6 hours. And I guess this is kind of important. If you've had hyperpara before and you're thinking about a redo surgery, And we think the problem is that you have a remnant, like half of a gland that was left behind before that's bigger. But I'd really like to know where it is, you know, and not randomly explore you and then ultimately after 6 hours find that it's between the windpipe and the spine or something crazy like that. So I think imaging can really help you make a decision about moving forward, because if you know where you're going to go, the surgeon can give you a pretty good idea of what he could nick along the way, he or she could nick along the way, or how easy or how hard it is. So are you ready for another operation? That's another question you really got to ask. And to figure that out, you have to know the risk, benefits, and alternatives. And that should be a question you always ask the surgeon. What are the risks of this? What do I get out of it? What's good for me? And what other things might I be able to do instead of surgery? Well, the risks of a redo operation include those common sense things, like if you have a cut anywhere, you could have bleeding and bruising, pain, infection, scar. Common sense, right, for having a cut anywhere. And then there's other risks that are very unique to the particular operation, like temporary or permanent damage to your voice box, which in MEN patients has been studied. Okay, so a large study in Europe looking at just MEN patients. The risk of having a nerve injury after a redo parathyroid is 2% in MEN patients. So we can answer it for MEN patients. Now, this is in expert centers in Europe. This is not in, you know, small towns in Europe. Okay, but we think it's no different really than a person who doesn't have MEN. Those are about the same odds. Temporary low calcium. Okay, I bet you're going to get it. That's the way this stuff works. Your calcium's been running high, and we go and fix it. It's going to run low for a while. That's really common and expected. Permanent hypopara. I'm going to show you in a minute what the odds are. It's pretty high. And then recurrent hyperpara is really high too. So we have to think about this before we go forward. What are the benefits? Well, we think we're going to improve or reverse the bone damage. We're going to probably stop making new kidney stones, at least for now, until the hyperpara comes back. And all those symptoms, remember that giant list that I showed you, three columns long, of all those neurocognitive things, anxiety, depression, low energy, about 75% of those get better. So that's on the benefit side of the equation. This is just data that I won't, because of how much time we're behind, I won't go through, but I'll show you just really quickly. These are people who have hyperpara and they didn't do anything about it. They just got watched in New York City at Columbia University. At the same time, they took half of the patients and they did parathyroidectomy on them. And this is the bone density zero line where they start, and then people get observed, bone density goes down over time. The people who had parathyroid, there's the zero line. Not here, it's there, because all of their bone densities went up. All of them. So if you got parathyroidectomy for hyperpara and your calcium was normal afterwards, your bone density went up. If you got watched, your bone density went down. And in some cases, at about 8 or 10 years, it really started to go down. Okay. So that's the benefits of having it done. All right, so what are your treatment options for recurrent hyperpara? This is where everybody starts. They usually watch it for a while and see what's going on. How bad is it? How fast is it getting worse? Stuff like that. Most people will move through medications, although most of them are designed to impact the skeleton. Bisphosphonates are like Fosamax and alendronate and those kind of drugs try to prevent you from having worsening osteoporosis. And then there's cinacalcet, which directly affects the calcium and the PTH level. But here's the thing, a lot of people get a lot of problems with their stomach on it. Their stomach doesn't tolerate it, and it also is pretty expensive. And the minute you stop taking it, the calcium goes back up. So it's one of those that's like also probably better for a temporary solution than for any kind of long-term solution. More surgery is, of course, what I do and what we talk about mostly because it's the most definitive thing to do. There's also experimental treatments that aren't FDA approved or done in a lot of places. And for example, they can inject alcohol into parathyroid glands in order to try to kill them instead of having an operation. And they do that at some places. I've actually operated on 2 people that had that done, and then it didn't work, like the parathyroid didn't get all the way killed, and then I had to go in. It's actually pretty painful to do that as a surgeon because when somebody gets injected with alcohol, that it's kind of like someone squirted super glue in their neck. So it can burn a little bit of a bridge. That's why I don't usually recommend the experimental therapies for patients unless they've kind of exhausted the non-experimental things and they really, really, really can't have another operation. So now I think it's time to ask the doctor some tough questions. And those tough questions go like this. Well, what's the chance that you're going to really cure me with another operation? And I think also you should ask, are you able to cryopreserve parathyroid tissue? And cryopreserve means that can you take some parathyroid tissue out of somebody and stick it in the freezer? And then later on, if they have permanent hypopara, you can thaw it out and put it back in the patient and it'll work again. Do you have the ability to do that? And they can do that at some centers, but not everywhere. So I think those are two important, tough questions to ask. This is what I promised to show you. This is the data on recurrence and persistence and permanent hypopara. And there's 3 types of operations that can be done. These are actually really the first operations that people might get for their hyperpara, the first time operation. Like you have something less than a subtotal parathyroidectomy where, you know, two parathyroids out of 4 are taken out, or 3 out of 4, something like that, or 1 out of 4. A subtotal parathyroidectomy means that 3.5, roughly. So all 4 of the parathyroid glands have been operated in some fashion. And then there's the total parathyroidectomy with auto-transplant. That means that all the parathyroid tissue is taken out of the neck, and then a small part of it is put somewhere else, usually in the non-dominant forearm. And so those are your 3 options. And I'll tell you the big difference between the 3. The more parathyroid tissue that we take out of people, the higher the chances of having permanent hypopara. So the operation is the highest risk of permanent hypopara is a total parathyroidectomy with an auto-transplant. The less parathyroid tissue you take out of people, the higher the chance is for recurrent and persistent disease. So you take a little bit of parathyroid tissue out, the chance of having the parathyroid problem come back is pretty high. So you're balancing all of this stuff, right? You don't want to have permanent hypopara, but you don't want to have recurrent disease. And that's why I was telling you earlier that most experts recommend a subtotal parathyroidectomy for patients with MEN1. So these are the odds for that. Persistent disease, 7%. Recurrent disease, 2/3 of patients, up to 2/3. Permanent hypopara, maybe as low as 0, but maybe as high as 1 in 5. Those are the numbers that, and this is, by the way, meta-analysis numbers. This is like, look at 30 reports in the medical literature and average all the numbers together and tell you what the average is. But these are the tough questions that you ask your doc. What's the chance I'm going to have permanent low calcium the rest of my life? And since I brought it up, I wanted to just mention this very briefly in a slide. These are the options. Anybody, by the way, have permanent low calcium here? Yeah, a lot of MEN1 patients do. Why? Because it had, what, 7 operations for parathyroid, right? Something like that? 4, okay. So at some point, if I operate on you 7 times, there's a good chance that you're not going to have any parathyroid tissue left after that last operation. So if you're in that boat, the options are calcium and vitamin D. That's the mainstay of treatment. People have to take calcium pills and vitamin D pills several times a day. And calcitriol, I think, is essential if your PTH is 0. Calcitriol is activated vitamin D that's taken usually twice a day. It helps your body absorb calcium. Magnesium has a role also in trying to keep that calcium up, as do drugs that called thiazide diuretics that keep you from peeing out your calcium so much. The most common one, by the way, is hydrochlorothiazide. So those are the regular pills. Also, auto-transplantation of parathyroid tissue. So that means if you just had your operation and now your PTH is 0 and it's not coming back, if that surgeon was able to freeze some of your parathyroid tissue and then could thaw it out and put it back, that would be great. Here's the problem with this. It only lasts for so long. It's like anything in your freezer at home. You can't freeze it for 2 years and then thaw it out and eat it. The same thing's true with parathyroid. You can't freeze it forever. The longer that a parathyroid gland is in the freezer, the lower the chance that it's going to be viable and able to work again when it's put into somebody when it's thawed out. And that, I'll tell you, it's about 6 months, and that's about where things start to go downhill. And there are studies of like going out to 2 years, trying to thaw out tissue that's 2 years old, and about 1% of the time it's going to work at 2 years. And I think that it starts to kind of poop out after about 6 months in the freezer. So if we're going to do this to somebody, it'd be nice to know before 6 months have passed that we need to thaw it out. Here's the other thing about MEN1. Sometimes if you wait it out, you've got some little teeny tiny parathyroid tissue somewhere, like in the thymus, that's just going to grow back, and it takes a couple of years for it to happen. Sometimes when you wait it out, the calcium comes up. Usually, though, we're going to see some measurable PTH at some point shortly after surgery. And then there's also recently approved by the FDA as of January of this year a new drug, which is recombinant human PTH, which is approved for the use in hypoparathyroidism. It's an injectable drug that's given to people, and it replaces their PTH. It's like giving insulin to diabetics. Seriously, it is. In fact, until January of this year, PTH was the last major hormone that we didn't have a replacement for. So this is the most recent one, and it's the last major one, and they were waiting for something that we could give for people with a PTH of 0. You know what? I've never given it to anybody. And as a surgeon, I probably never will. But but I think it is. I think it's once or twice a day. But I don't really know. And now we're streaming live, so the whole world knows I don't know. But well, I'm sure somebody will write as a comment on the website what the dose is and how often. So I've never used it. It's a new one. All right, so let's get off of that. All right, so last slide. I think these are the take-home points. So know your treatment options. Take some time going over everything and figuring out what to do. And make your decisions about whether you observe it or take medicine or go forward with surgery based on the risks that are particular for you. And the risks are different if you've already had 4 operations than if you hadn't had any. Okay, those are very different. And also with the benefits that you might gain from it. And then seek out experts with experience in treating MEN patients. And I think that for anticipated known multi-gland disease, having things like cryopreservation of parathyroid, that might be really important for patients as well. That's why I say look for experts who have experience. All right, that's it. So that's all I have, and I'm probably over my own time. I'll give you